Hello, everyone. Dr. Nick Verma here with another episode of Things I Didn't Learn in Med School. Today, I want to talk about a recent article that came out in JAMA, JAMA Psychiatry, dated August 24th, 2022. It says percentage of heavy drinkers following a psilocybin-assisted psychotherapy versus placebo in the treatment of adult patients with alcohol use disorder, a random clinical trial. So I think there's a lot of buzzwords around psychedelic use and psilocybin and MDMA assisted therapy and ketamine therapy, which is definitely a fascinating topic and something that I have heard a lot about, read a lot about, but it's not something that we really learned in med school. When we were in med school, we actually had some our lectures on these topics in our psychiatry portion of our lecture series. It was funny because our lecturers kind of were hinting at them trying possibly ketamine, possibly psilocybin, which is the active ingredient in when you hear magic mushrooms, or possibly trying LSD or acid. So it was kind of funny to hear their perspective and really not know any exposure to this outside of what we read in the textbooks and stuff growing up. And obviously there's a whole counterculture that's based around psychedelic use or hallucinogenic use, whatever you want to call them. But this topic and this JAMA article came out because this is something I've actually been following for quite some time now. Ever since medical school, probably my second year, I started getting really into podcasts, and I was listening to a lot of Tim Ferriss' experience, or Tim Ferriss show, sorry. And he would bring on these guests that would talk a lot about psychedelics, and I guess this is the time that he was starting to get more interested in it, and kind of put me down a deep rabbit hole of talking to some people about what this means for the future and how well this kind of stuff works for psychiatric disorders. And I read a few books about it back then, and as med school got more demanding, as residency got more demanding, I stopped following some of the literature, most of the literature actually. But I would, whenever something would come on one of these shows, I would kind of hear what their experiences were and what their results were. So I think I find it interesting still. But I feel like now it's becoming so popular, it's kind of tilting the other way, where people might think that, oh, it's going to cure everything. Like this article, for example, says highly suggested that it's going to help people with alcohol use disorder. Now, I'm not saying it won't, and I'm not saying that there's a time and place for it. I think just with a headline like that, people are going to go out like, oh, I'm a heavy alcohol user. I'm just going to take magic mushrooms and, I'll be cured. Well, that's not the point of the article. The point of the article really says is psilocybin-assisted psychotherapy versus placebo in the treatment as well. So both groups had intensive psychotherapy. So it's not just a panacea like, oh, just take it one time and you're done, but it's the integration work. I think that's an important topic that a lot of people aren't getting when you hear about these things. So I just want to read the results briefly. It just talks about 95 total participants randomized, as we know. One group got the psilocybin, the active ingredient in mushrooms. And that actually gets converted to psilocin, which is actually that real active ingredient. But psilocybin is what the precursor is. And then the placebo group took Benadryl. And essentially what the outcome measures came to, the percentage of heavy drinking days 32 weeks out was 9% for about 10% for the psilocybin group and 23% for the Benadryl group. So it's a mean difference of 13.9%. And also the average drinks per day were less in the psilocybin group. So that's great. I think it's a great study to look more into this. I think there were a lot of studies that were being done in the past, back in the 70s, before there was this big war on drugs. And I think that there was they were doing a lot of studies, and we can track back and look into them. And there was a lot of government pushback. There was a lot of other pushback from the culture that would kind of hold people down to not use these in their studies. And there's actually an interesting book, and I don't know the name of the book off the top of my head, but it was essentially a diary of someone and their experiences through all this, and how it like messed up their life, turned them psychotic, et cetera, et cetera. Well, apparently that whole book was not real, that diary journal, and that was something that was published and given to the government, who made their decisions. Um, but anyways, that's not to beat down a point of governmental regulations and stuff. That's not my point. I think I just want to take a cautious eye when we start talking about these substances and these potential medicines that could be helping thousands of people in the future. And the reason I found this interesting is because everyone immediately posts this on their Instagrams and Twitters and whatever. LinkedIn. I saw everyone. It's like, okay, cool. So let me read the exposure, and then I went down to, what were the limitations. So it's really funny because they say, first off, they know the Benadryl was ineffective in maintaining blind after administration. It's not. It wasn't impossible for people to say. It's like, yeah, you're on a psychedelic trip right now. We can tell, or as a patient, they could probably tell versus just Benadryl, right? So that's one thing. So couldn't really be blinded. There could be a lot of influence on that, bias because of that. So that was a challenge on both sides, the researcher and the study participants. So second, a lot of it was self-reported drinking habits. So that could also have a lot of bias because that doesn't necessarily say that, hey, that's the most active, appropriate way to test these kind of things. And also there's a high dropout rate. Only 53.8% of the participants that were treated actually followed up. So it sounds like to me a bunch of people just wanted to try an experience to get high and go through the therapy. Not get high, take that back, sorry. Want to just have a psychedelic trip and have some therapy and see what they result from it, with no intentions to follow up. There's tons of reasons why people don't follow up with studies, and this is one of the problems with studies that look back and try to regather some data from people. Third, you couldn't separate between genetic variations, ethnic variations, minority groups, et cetera, which we know that can play favorably in people that have addictive qualities. And then other things were, it can't be generalized to the bigger population. We know that with most studies. What do we say? How many patients were in this study to start with? So yeah, 95 participants again. So they started off with a lot more, and then how many dropped out from the beginning to the end? With that, like I said, that 53% that dropped out. The few other limitations that they quoted were the two group designs does not permit evaluation of the effects of psychotherapy or the interaction between psychotherapy and the medication. So they weren't able to dissect if this was actually just the psychotherapy that was working or the medication or a combination of both. And that in itself would be a pretty interesting study if we put a group with intensive psychotherapy and without the psychotherapy, and they both got psilocybin, to see how that head-to-head group would go. So that'd be something interesting that I'd like to see in the future, potentially. It also doesn't say what the effect is and how long this might happen. Maybe it was just a short term in this 32 weeks, but who knows if this is lifelong. So anyways, I want to say this because I'm not anti these kind of studies. I think when a popular journal like JAMA just publishes it like that, people get excited, and we have a lot of people that don't want to push the culture, and we have other group of people that do want to push the culture. For example, MAPS, which is I'm trying to Google what it stands for again. The Multidisciplinary Association for Psychedelic Studies. They're doing as many vigorous studies as they can on these kind of topics and trying to produce high-level data. From the anecdotes that I hear and the books that I read and the podcasts that I listen to, it seems to have a lot of positive effects. This stems from ketamine therapy. We'll talk about that a little bit. Psilocybin therapy and MDMA, or street drug as known as Molly or ecstasy. Those studies that have been very beneficial for participants in these study trials. Again, these are really hard studies to blind, especially doubly blind, or single blind or double blind, actually. So it's kind of interesting, what are the results? But the big thing I want everyone to realize is these aren't just studies in a general population. These are very selected patients. They have psychiatric disorders. They've been well screened. They've been well vetted to make sure, hey, we're going to want to do this right. We don't want to cause any problems down the road. So that's one thing to keep in mind. And two, I think we know that they're going through intensive psychotherapy alongside of these. So it's not like people going to a rave and partying on these drugs and say, oh, I've had a life-changing experience. So that's another thing to keep in mind. Now, with that being said, I have heard a lot of studies. I've read a lot, heard a lot of podcasts that people say that taking some of these substances have been a very life-changing experience. For better or for worse, I don't know, but usually they say it's opened their eyes. They see the world in a different way. This is definitely something that needs to be studied more because, again, these are not just innocuous medications. These do have a potentiation to trip someone into psychosis and forever. It could cause some sort of emotional or mental or physical trauma to you. Sam Harris, who's a pretty famous podcaster, neuroscientist, talks about one of his trips where he took such a heavy dose of mushrooms that the next thing he remembers, he was waking up face up in a river in the side of South America into a really small village where he thought he was going to die. And he was all bloody and scarred up and stuff. It's like, this is kind of scary stuff. You don't want to just go out and take these medications or potential medications or substances and think that you're going to get cured of some problem that you might be experiencing. So that's kind of enough about the negativity or the warnings, I should say. If anyone does, have interest in this, I feel like you need to get with somebody that knows exactly what they're talking about. Get with someone that's a neuropharmacologist, neuropharmacologists, and get with people that have done studies, people in the right setting, in the right environment. I think these are really important things to do if you're going to do these things. And again, I'm not condoning any of this. I'm not supporting anyone to go out and try this on their own. But if you have interest, you should really look for real high-level clinical trials to make sure that you're in a safe environment if that's what you're looking for. And we don't know what the future is going to hold for this. I would like to bring these things more to the mainstream for the patients that need it. We're starting to see that the MDMA therapy has a lot of benefits for patients with post-traumatic stress disorder, which would be fantastic. We know that psilocybin can be very effective for patients in the end of care life, and they become less attached to their own death, which could be a very bonding experience, especially at that really hard time when we're in our palliative care years or pathologies. And even more so, we're starting to see a lot more studies and a lot more clinics in general opening up with ketamine therapy, which can help with anxiety, depression, and can potentially even help with pain in the long run. So I want to talk briefly about some of these things, and we'll kind of hit some highlight points, things that I wasn't aware of back then. I'm starting to become more aware of now. I'm not heavily into this research right now. I'm still kind of testing the waters and understanding like what people are doing, what studies are out there, what studies are good studies, what studies are bad studies. And I really want to put up a cautious flag to everyone out there to, don't think that this is some sort of panacea that's going to help the world with all the world problems. I think there's intensely positive things that could come out of this, but I also think there's a lot of negatives that can come out of this. And that's just, why we do these heavy studies in the long run. And with that being said, a lot of these are being fast-tracked to get FDA approval because we're seeing such good results. And, I want to say, like, for this alcohol study or just any studies, how effective is antabuse for alcoholics or naltrexone with an IM injection? They're highly effective, but people don't voluntarily go and do that because they don't want that negative thing because that addiction might be holding them back. Now, there's something to be said that, maybe these people have some sort of trauma or something that's holding them back, and that's why they're addicted. So maybe these psychedelic medications can help them overcome those feelings, and that's why they lose their addiction. And that's actually something that's been allegedly said, is that Alcoholics Anonymous was based on the 12 steps, but part of the 12 steps was psychedelic experience using LSD. Was it lysergic acid diethylamide? God, it's been a long time since I've done chemistry. Anyway, so that's something that was allegedly out there for a while, and that meaningful experience brought them closer to God. And you'll hear a lot about this in the psychedelic world of these feelings that they were closer to God and felt more like one, and they had more control over their body and their lives. So again, it could be an interesting way to a pathway if we have the right steps, the right therapy, the right integration, whatever you want to call it, without just taking it and feeling you can help yourself. Because that's actually a story that I find interesting, that happened to me. My intern year, there was a young kid, 15 to 17 years old. They came to the hospital and had taken a bunch of psychedelics and went into psychosis. And they were in the ICU for I actually don't even remember. It was in the ICU for at least 5 days. And then we finally downgraded him, and he just was never the same. And you could tell, and the child's mother was, emotional. And it was interesting because I heard so much judgment by the attendings and the nursing staff and all these people. And like I said, I was kind of listening to what the patient had to say, and what I heard on Tim Ferriss, and I heard some of these other speakers talk about. And the patient was just trying to get an escape because the patient was highly depressed, highly anxious, had a lot of problems, and all these things, just trying to get away. So I'm not saying it was the right thing to do. I think that's an example of doing it the wrong way and not getting integration and making sure in a safe place, in a safe environment, doing it in a legal way. All these are illegal right now. There are some states that have decriminalized some of these substances, but that doesn't necessarily mean it's federally legal. Having a hard time talking tonight, clearly. But that's an example of this could be detrimental for people. I think a lot of people take these substances and go out to raves and concerts and all these things. It was obviously really big in the 70s as well, even before that. But doing that versus doing it in a religious ceremony, I feel that connectedness to music that you might hear someone describe back then, it could be very easily relayed of connectedness in a religious ceremony or a meaningful ceremony, where a lot of places will do these ceremonies as an integration of families, or integration, or some sort of ceremony that has some meaning behind it, and it puts more meaning in all around. So I think that's what's funny, or what's important, is the framing matters a lot, especially in psychopharmacology, because we don't know exactly what these substances do. We have a lot of suggestions, but we don't really know. We can do fMRIs, we can check our biomarkers, we can do all these amazing things Western medicine can do, but we don't really know. And we don't know how it's going to affect person to person. We don't know the difference in pharmacokinetics or the pharmacogenetics and all these kind of things. So they all really do matter. Quickly at the towards the end, I want to talk about a couple other things. It's just I'll start with the ketamine therapy. So there's a lot of ketamine therapy, IV therapy places out there. Intranasal ketamine was approved recently for medication-resistant depression, and can help with patients that are suffering from that. I think there's another indication for it as well. Potentially PTSD. Don't quote me on that. But there are a lot of ketamine infusion centers that do IV infusions for depression and anxiety and post-traumatic stress disorder, and a variety of other things. The infusions go for about 30 minutes, 45 minutes, an hour, give or take. So that's, you have to go multiple times, and these are cash paid. So there's a very shady part of the world that are doing it for cash pay just because they want to get multiple hundreds of dollars each time these patients come in for their psychiatric disorders that they're dealing with. So that's something that doesn't run well with me. So if I ever do see a ketamine therapy place, I want to like kind of dive in. What's your goal? What's your target here? Are you actually helping people, or are you just trying to make money? Also, who's running it? Is it someone that's been well versed in the research? Is it someone that's keeping up with the data? Is it someone that's read the books and had experiences where they've talked to other practitioners or gone to some of the labs and seen other participants and study participants? These are some things that you need to look into if you have interest in these therapy centers for patients or for yourself. There's also a routine for IV ketamine for pain. It's a lot longer, to take anywhere from 3 to 4 hours. Infusion rate's different, side effects are different, so that's something to keep in mind as well. We do use ketamine a lot of times in the OR. We use a lot of times in children anesthesia, and the reason we use it because it's an NMDA dissociation. It disassociates the NMDA receptors. So once you get that dissociation, so we'll run that. It's an NMDA agonist, so it causes a dissociation, and that separates the patient or the person from that real experience. So this kind of makes sense. If a patient has a post-traumatic stress disorder or anxious or whatever, and they're having problems disassociating their identity with that, then it would make sense why these things work in that sense. And I think that's why it's important to have someone to help integrate that into your life and show you what that actually means. Similarly with pain, it's when my medical student teacher was explaining this to us, when she had her ketamine trip, she felt like she was up here looking down on herself, which is really, really bizarre concept for someone to understand. But that is something that they do explain, and I think that's why it's a powerful agent. Ironically, xenon, the noble gas, or is it noble gas? Xenon, the gas, is actually as well acts in the same way, but for whatever reason, apparently it's banned in the U.S. as an anesthetic agent. I don't know much about this. My friend reminded me that Hamilton's Pharmacopoeia, which kind of talks about psychedelics and how they might be used in culture and society. He talks a lot about it. So if you have more interest in xenon gas as an anesthetic, go watch that. So that's where the ketamine therapy might come into play. And I think we're still doing research. I think we're trying to figure it out and how it works. The next is the other class, psychedelics, where I'm going to lump in psilocybin and LSD together because they both act similarly on the serotonin 2A receptor. And they mainly focus on that, but that's what they believe the psychedelic effects come from, are those receptors. So another recent article came out kind of disowning the SSRI theory, which I find okay, like cool, you did find that. So everyone's like, see, I told you SSRIs don't work. I told you, all right, so SSRIs don't work, we shouldn't give patients SSRIs, et cetera, et cetera. Serotonin, it's blown up myth. But a lot of the same people that are saying that are peddling psychedelic use. So now we see it works on the same receptor, the same serotonin. So just think about that before you follow someone that's very anti SSRI. It's the same serotonin, right? Different receptors, sure. So we can't just throw out everything with that study that kind of disproved the single monoamine theory of serotonin. So just keep that in mind, especially when you talk to these people that are peddling for psychedelic uses and they're anti-SSRIs. Bring that up. Tell them work on the same receptor. So have them explain that, because I guarantee they won't have a good answer. And I don't have a good answer. And I have a lot of really intelligent friends that are really deep into this research. They don't have a great answer. They say that serotonin is just one pathway that affects depression. It's not the only, and I think that's why it didn't. That's why that study showed what it did. But so just keep that in mind. So, psilocybin tends to have a much shorter half life, clears the body a lot better than LSD. Dosaging, you know, there's different books and different protocols out there. Not going to get too much into that. I think these things will have a space in the future. I think we don't want to get too bogged down by what it does for everybody, because I feel like a lot of people are like, oh, it's going to help me with this, it's going to help me with that, it's going to help me with this. Like, I think we should really work on what it's going to help people for. I don't know if I'm not a politician. I don't know if decriminalization is the right way. I don't know if only to use it in controlled settings or what. But if it was me making the decision, it should be only certain types of practitioners should be able to offer it. Certain types of physicians, psychiatrists. They should be well regulated. They should be heavily studied and critiqued, kind of like pain clinics are now, or how medical marijuana dispensaries are now, or even just marijuana dispensaries. They need to be highly regulated. I don't think it's fair for our people just to go out and try magic mushrooms or LSD, especially as we know that street drugs are becoming more common, and the more common it can become, they start cutting them with different things and sheeping them and causing overdose and deaths. And this isn't supposed to be a hysteria of overdose and all that kind of stuff. We're in a world of a mess because of all this right now, but I just don't want these tools that might be beneficial to go down the deep end of where opioids are now. Because opioids were a great tool. They are a great tool for the right patient, but they're not for every patient. And I think it's the same with this. It's not for every patient. It's not for everybody. And I think using it with a very regulated way would be the most intelligent way to handle this. So with all that said, I think important to say at this point, and I'll also put in disclaimer, is like, this is by no way means me supporting you to go try psychedelics or MDMA or any other illegal substances. I think that this is just an educational piece to explain to people what these things can do and they may not do. I don't know if this is actually going to be able to stay up, because I do talk about these things, but hopefully because this is just educational purposes, that I'm not violating any of YouTube's bylaws or anything. But yeah, so that's about it for tonight. If you guys have any questions, feel free to message me. I have tons of resources if you want to read more about these kind of things and you have interest. If you have interest in getting involved with the studies, I recommend checking out MAPS. I know U.S. University of San Diego is doing a lot of studies. I believe there's more in Washington, University of Michigan, NYU. A lot of these places are starting to do some pretty heavy studies. So I think it's important. I think we're at the very beginning of the importance of this, the reemergence of these kind of studies. So, and I'm happy to guide you guys in the right way. I don't know if I'm the right person to answer every question, but hopefully I can put you in the right direction if that's what you want to do and you have more interest. And I definitely do have more interest. I'm going to keep reading about this. I'm going to keep giving out warning messages like this and try to help out more people. Because if this is the future, I think the most important thing is getting the information out for patients and making sure that they're in the right setting for it. So everyone, have a good one. I'll talk to you soon. Take care. Bye.